You can have the floor, please.
Thank you. Okay, Chief, thank you so much. Good evening, my teachers, my seniors, and my colleagues. This evening, we're going to talk on sympathomimetics and antagonists. As a way of using the following outline: the introduction, classification, the sympathomimetics, and adrenergic antagonists. Then, as a way of introduction, sympathomimetics are agents which in general mimic responses due to stimulation of sympathetic nerves. These agents are able to directly activate adrenergic receptors or indirectly activate them by increasing norepinephrine and epinephrine levels. Chemically, these drugs are catecholamines or are structurally similar to the catecholamines. And there are three naturally occurring catecholamines. We have the dopamine, norepinephrine, and epinephrine, as well as these are the naturally occurring ones. Then we have various synthetic amines. For example, we have the dobutamine and isoproterenol. Then the next slide, this is just the summary of the synthesis of the catecholamines, the noradrenaline, dopamine, and then the adrenaline. And the first agent for the synthesis is an essential amino acid called the phenylalanine that is being acted upon by the phenylalanine hydroxylase to converted to tyrosine. Then from the tyrosine hydroxylase acts on the tyrosine to convert it to dopa. Then the decarboxylation of dopa gives dopamine. And then with hydroxylase, dopamine beta hydroxylase converts dopamine to noradrenaline and adrenaline. Hence, 5 enzymes are involved in the pathway of the biosynthesis of catecholamines. The next slide. The first enzyme, which is the phenylalanine hydroxylase, then the second enzyme, the tyrosine hydroxylase that converts to dopa, then after the decarboxylation of dopa to dopamine. The final enzyme is now the noradrenaline N-methyltransferase that methylates noradrenaline to adrenaline. The next slide. Then the classification of the sympathomimetics. This is just like a summary of the catecholamines and then the non-catecholamines, what is particular characteristics about them. The catecholamines, we call them, they are sympathomimetic amines having catechol nucleus, while the non-catecholamines they don't have the catechol nucleus. And the catecholamines, they are not effective orally. They are better given intravenously and are easily metabolized by the monoamine oxidase enzyme, and they act quickly. They have very short action and does not cross the blood-brain barrier. These catecholamines, they have no significant central nervous system effects, and they act directly on the receptors. And the examples of the catecholamines I have said in naturally occurring ones, epinephrine and norepinephrine. While the non-catecholamines are devoid of this catechol nucleus, they are effective, it can be given orally, and they are relatively resistant to the monoamine oxidase enzymes. They have better prolonged action and easily crosses the blood-brain barrier with significant central nervous system effect. They act indirectly as well as directly. For example, the amphetamine, the ephedrine. Then we also, the next slide, also another classification based on mechanism of action of these agents. We have the direct acting agents, those ones that act directly on the receptors like the epinephrine and norepinephrine. The ones that act indirectly, indirect acting agonists, we have the amphetamines and the cocaine, while the ones that have mixed action. By indirect, it means that either they cause the stimulation or the release of the epinephrine and the norepinephrine, while the mixed action, the ones are the ephedrine, pseudoephedrine. Then the next slide is a diagram that summarizes the sympathomimetics And you can see it's a little bit tiny. We have the direct acting, we have selective and non-selective. Then we have the mixed acting, the indirectly acting, and those ones that are indirectly, either they are releasing agents like amphetamine, and then the ones that prevent reuptake of these epinephrine and non-epinephrine, like the cocaine. And then we have the monoamine oxidase inhibitors, the ones that prevent degradation of these catecholamines. Then adrenergic receptors. Now, the next slide. Okay, the adrenergic receptors, there are specific molecular structures in or on the effector cells with which catecholamines or sympathomimetic drugs act in order to elicit the characteristic response of the cells. Then we have the adrenergic antagonists also bind to these receptors and prevent those responses mediated by the endogenous or the exogenous agonists. So the opposite of the sympathomimetics is the antagonist. Currently, there are two general types of adrenergic receptors. We have the alpha and beta, then with the various types. So all of the adrenergic receptors, they belong to this family of G protein coupled receptors that's linked to heterotrimeric G protein. So most of them, these adrenergic receptors, they have some structural resemblance, but different receptors, they regulate distinct physiological processes by controlling the synthesis and release of variety of second messenger or the activity of ion channels. So we have the alpha, alpha 1, alpha 2, beta 1, beta 2, beta 3. We have the agonist and then the antagonist. Then there are two main groups of the adrenal receptors. We have the alpha and beta, and then these have lots of subtypes, about 9 of them. Then the alpha is divided into have the alpha 1, that is GQ coupled, protein coupled receptors, while alpha 2 is GI coupled receptor. Then the alpha 1 has 3 subtypes, alpha 1A, 1B, and 1D, while alpha 2 has 3 subtypes equally, 2A, 2B, and 2C. And then we also have beta receptors, beta 1, beta 2, and beta 3 receptors, and they are all coupled to GS protein. So then this the next slide will show us these adrenergic receptors and the locations where they are found. Then the alpha 1 receptors are localized in the blood vessels, and then the prostatic urethra and the eye, while the alpha 2 located in the central nervous system, the blood vessels, and the gastrointestinal tract. The beta 1 is mainly localized on the heart, and then in the kidney, the juxtaglomerular cells of the kidneys, while the beta 2 is localized in the lungs, the uterus, GIT, bladder. We will see the actions one by one. The one that is predominant, you see either is causing a vasodilatation or vasoconstriction. Then the beta 3 is localized in the adipose tissues. Then the next slide, this is not clear, no, but this is just the summary of the mechanism of action of these adrenal receptors. We have the epinephrine or the norepinephrine. They are receptor ligands to either this alpha 1, alpha 2, or the beta receptors. So the alpha 1 couples to the Q subtype of that is this Q subtype of the G protein. And coupling, this will result in increased, in the next slide, will result in increased intracellular calcium and subsequent smooth muscle contraction, while on the other hand, the alpha 2, on the other hand, will now couple to the subtype I of the G protein, the receptor. And the coupling on this causes a decrease in the neurotransmitter release, as well as a decrease in the CAMP activity that will result in smooth muscle contraction. Then the beta receptors couple mainly to, they couple to the subtype, the GS subtype, a protein ligand, which this increases the intracellular CAMP activity that will result in an increase in heart muscle contraction, smooth muscle relaxation, and then glycogenolysis. Now, the physiological and the pharmacological response. So the actions of the sympathomimetics can be classified into at least the 7 broad types of responses. Now, one, we have the excitatory action on smooth muscles. The action of the sympathomimetics leads to contraction of the vascular smooth muscles. Inhibitory, they have inhibitory action also on smooth muscles, causing like the inhibitory action is mainly like that. The table that I just showed briefly is on beta 2 that will cause relaxation of the bronchiolar smooth muscles. Then they have also stimulation of the heart. The heart is the beta 1, leading to increased heart rate, contraction, and then conduction. Then the fourth is the metabolic action. Example, the breakdown of glycogen in the liver that will result in increase in glucose. They also have endocrine action, increasing or decreasing insulin release. 6, they also have action in the central nervous system. And 7, action on the nerves, increasing or decreasing the transmitter synthesis or the release. So the next slide, the response to sympathomimetics often can be predicted on the basis of knowledge of the selectivity of the agents. That is the selectivity, whether it's alpha 1 or alpha 2. Some can have all of them, but have some have more action on particular receptor. So the response to this sympathomimetic often can be predicted on the basis of knowledge of the selectivity of the agent for reacting with a specific alpha or beta receptor, and the physiological response governed by these adrenergic receptors in specific cells or tissues or organs. So the response of any cell or organ to sympathomimetic drug is still dependent on the density and proportion of those receptors, that is the alpha or beta receptors. An example is in the bronchial, the smooth muscles of the bronchioles that we have principally the beta 2 receptors, as I previously said. Then the norepinephrine has little effect on this bronchial smooth muscle effect, since norepinephrine has little activity on beta 2 receptor. So on the other hand, epinephrine or the isoproterenol will relax the bronchial smooth muscles because of what? Its ability to activate the beta 2 adrenergic receptors that is concentrated on the lungs and the bronchial smooth muscles. So the next is very tiny, but when you get the slides, you will see the peripheral adrenergic receptors and then the responses. So for each, the eye, the heart, the blood vessels, the lungs, the gastrointestinal tracts, the responses they have, depending on whether it's alpha 1 or beta 1, beta 2. Even those that have beta 1, beta 2, one predominates, either beta 1 or beta 2. So the next slide, we'll talk briefly on the various endogenous catecholamines like epinephrine and norepinephrine. Both are released from the adrenal medulla, and also there are also neurotransmitters in the central nervous system. The endogenous catecholamines, the dopamines, norepinephrine and epinephrine, they are rapidly metabolized by the COMT enzyme and then monoamine oxidase enzyme, and they are inactive when given by the oral route. And these epinephrine, they have very short duration of action and do not penetrate. Okay, I've said that in the past. Then epinephrine is non-selective and it can directly activate all adrenergic receptors. So it acts on alpha 1, alpha 2, beta 1, beta 2, and beta 3. So since epinephrine is a potent stimulant of both the alpha and beta receptors, its effect on target organs, they are complex. Epinephrine is a potent pressor drug and has prominent cardiovascular effects, especially after parenteral administration. And the mechanism of action, the next slide, the mechanism of a rise in the blood pressure by epinephrine is one, they have direct myocardial stimulation, which increases ventricular contraction. That is, they have both positive inotropic effects, increases heart rate, positive chronotropic effects, and vasoconstriction in many vascular beds. So we have heart rate, cardiac output, stroke volume, ventricular work, they are all increased due to direct cardiac stimulation and increased venous return. So the next table we see is the summary of the action of epinephrine on both the alpha and beta receptors. And at low doses of epinephrine, it has more of beta-2 effects that will give us vasodilatation, but at high doses, it has more of alpha-1 effects that has more of vasoconstriction effects. Okay, the next slide. Still on epinephrine, okay, I've already talked about the bronchodilation effects, and it acts directly on the bronchial smooth muscles. Then also hyperglycemic effects because of increasing glycogenolysis from beta-2 effect also. Then release of glucagon from the beta-2 effect and insulin. It also increases lipolysis as agonist activity on the beta-3. Beta-3 is located on the adipose tissues. So epinephrine also acts on the adipose tissues too. Because the next slide, 2 slides up. So norepinephrine, the next one, is also a potent pressor agent and increases both systolic and diastolic blood pressure and peripheral resistance. But unlike epinephrine, norepinephrine does not activate beta-2 receptors in skeletal muscle, skeletal blood vessels, and there is no decrease in diastolic blood pressure. Like epinephrine, norepinephrine directly increases all aspects of the myocardial function due to activation of the beta receptors. And norepinephrine is used to treat various forms of hypotension. So the next slide is the summary of the norepinephrine has alpha-1, alpha-2, and beta-1 receptor effects with similar potency as epinephrine, but it has a very little effect on beta-2. So increases peripheral resistance, that is alpha-1, and both diastolic and systolic. So maybe we'll move therapeutic uses, can be used in cardiogenic shock, but dopamine is preferred as norepinephrine is associated with renal shutdown, while dopamine has a vasodilatation of the renal vessels. Then the side effects of this, we have excess palpitation can lead to palpitation, irregular heartbeats, cardiac arrhythmias, cerebral hemorrhage from excessive elevation of the blood vessels that can give hypertensive encephalopathy and hemorrhage, headache, tremor, and restlessness. Then the third one is dopamine, is the third naturally occurring catecholamines, and is the immediate precursor of norepinephrine. You can see when I talked about the biosynthesis, and is an important central nervous system neurotransmitter and an interneuron mediator in some autonomic ganglia, and perhaps a local hormone in the kidneys. Dopamine can directly activate alpha-1 and beta receptors and can also evoke the release of norepinephrine from sympathetic neurons and is therefore classified as mixed acting sympathomimetic. By being that mixed acting, it enhances the release of norepinephrine from the vesicles and also has both direct and indirect action on the vessel. So dopamine is a substrate for both monoamine oxidase and then COMT enzymes and is inactive orally. In addition to its effect on alpha-1 and beta receptors, it can activate D1 receptor located in the renal, the mesenteric, and coronary blood vessels, leading to dilatation. And activation of D1 receptor on renal tubular cells decreases sodium transport and produces natriuresis. Dopamine is used clinically to treat cardiogenic shock, congestive heart failure, and acute renal failure. And one of the side effects in high doses is vasoconstriction. There is something that is very important about dopamine, the features that distinguishing it from norepinephrine and epinephrine. At low doses of dopamine, it acts on the D1 receptors that will give us renal vasodilatation. So like patients with cardiogenic shock and hypoperfusion with AKI, when dopamine is given in low doses. They give then at intermediate dose, 5 to 10 microgram per kg, they act on beta 1 receptors that increases cardiac output. Then on high doses, the dopamine, it acts as a potent vasoconstrictor. Next two slides, because I've already said this. Okay. Then we have the synthetic ones. The one we just talked previously is the naturally occurring. Then the synthetic one, we have the dobutamine and isoproterenol. So isoproterenol is a synthetic catecholamine with activity on all beta receptors. It has beta 1, beta 2, and beta 3 activity. And it is rarely absorbed when given parenterally or as an aerosol. And it is also metabolized by the COMT and enzyme and the monoamine oxidase. Though it is a poor substrate for monoamine oxidase and is poorly taken up by the sympathetic neurons. It produces both positive inotropic and chronotropic effect, leading to an increase in cardiac output with unchanged or increase in systolic blood pressure. It will relax non-vascular smooth muscles that contains the beta 2 receptors. So we talked the beta 1, beta 2. The beta 1 is mainly on the heart, beta 2 on the lung, and then 3 on the adipose tissues. Then the dobutamine, let's go to dobutamine. Dobutamine, please let me plug this thing is trying to go off. Excuse me, please. Okay, thank you very much. So dobutamine, the dobutamine, although it's been often thought to be a prototype of beta 1 selective agonist because of, but the pharmacological effects are complex. And dobutamine has two isomers. We have the two forms, the levo and then the dextro isomer. The levo isomer is a potent alpha 1 receptor that has a potent pressor effect, while the dextro isomer has alpha 1 receptor, is an antagonist, which can also block the effect of the levo dopamine. Then the dextro isomer is also a more potent beta receptor agonist than the levo isomer. So we have the levo and then the next slide. Okay, this is talking about dobutamine. This is just what I have just explained. It has both positive inotropic effects, which is predominantly by the beta 1 receptors, and then also has both alpha 1 agonist and alpha 1 antagonist by the levo and then the. So the therapeutic uses of dopamine is used in patients with heart failure, those with myocardial infarction, those that underwent cardiac surgery for short-term management for acute congestive heart failure. So the next slide, I think this is just exactly what I've just said. Then the beta 2 agonist. The beta 2 agonist will have the albuterol, the metaproterenol, the phenoterol, formoterol, salmeterol. These are long-acting, while salbutamol is a short-acting. Then ritodrine is also one of the beta 2 agonists. So the selectivity for beta 2 receptors theoretically allows this drug to relax airway smooth muscles at doses producing minimal activation of the heart. So many of these drugs, the beta 2, located mainly in the lungs, the uterus, GIT, and the bladder. They've been found useful in treatment of asthma, bronchospasm, chronic obstructive pulmonary disease, and then premature labor. And side effects result from excessive activation of the beta receptors that include tachycardia, arrhythmias, tremors, increased bronchial hyperactivity. So the next slide shows us what I have just explained. The selective beta 2 agonists, those with long duration, have a longer half-life, And ritodrine also may cause relaxation of the uterus in premature labor. Then we have alpha-1 selective agonist. We have the phenylephrine and midodrine in this group. They also have some other alpha-1 selective adrenergic receptor agonists, and they activate adrenergic receptors, alpha adrenergic receptors in vascular smooth muscles that will increase peripheral resistance and elevation of blood pressure. Okay, the next slide. Most of these alpha-1 can be given orally and can be used to treat hypertension, including orthostatic hypertension as in midodrine. They can also be used as nasal decongestants, like in phenylephrine. The midodrine is an orally effective alpha-1 agonist and is a prodrug that is used to treat orthostatic hypertension. Okay, sorry. Okay, the next slide. Let me change another system. My battery is going. The next slide. Okay, move the slide. The next one. Thank you. Okay, continue. We'll go to the alpha-2 selective agonist. Then the alpha-2, we have in the class, we have clonidine, aproclonidine, methyl-dopa, and tizanidine. They are all alpha-2 selective adrenergic receptor agonists. Although the principal receptor is the vascular smooth muscle, that is in the vascular smooth muscle, the principal receptors we have there is alpha-1 type, but there are alpha-2 adrenergic receptors as well, which when activated can promote vasoconstriction. So alpha-1 is mainly also seen in the blood vessels, the prostatic urethra, and the eye. Now, although, okay, I've said that, therefore, it's somehow ironic that many of the alpha-2 selective adrenergic receptor agonists are used to treat hypertension, but we'll understand why they are used. How? The ability for this alpha-2 to lower blood pressure, however, is the result of activation. There is activation of alpha-2 adrenergic receptors in the cardiovascular control center in the central nervous system. So activation of this alpha-2 receptor at this side will decrease the sympathetic outflow that will cause a decrease in the blood pressure. And there is some evidence that clonidine sympathoinhibitory action is partly mediated by this action on the imidazoline receptor in the brainstem. So then the alpha-2 receptor agonist continued. Sorry, let me put on light. The light went off now. Okay. The second major use of some of these drugs is they are used to decrease the production of aqueous humor, because we have the alpha-1 receptors in the eye, thus reducing intraocular pressure in the eye in patients with open angle glaucoma. Okay, the next slide. That's clonidine. I've just talked about it. Then let's move 3 other slides downwards. Then we have the indirect and mixed acting agonists. The indirect acting, or those ones with mixed acting, that is, they have both direct and indirect. We have amphetamine, methamphetamine, and ephedrine. These drugs, they have powerful central nervous system stimulant action, especially amphetamine and methamphetamine. And that's why in the recent past, they've been drug of abuse among the youths. And in addition to, they also have both peripheral alpha and beta action. And most of these drugs can be taken orally, and they have long duration of action relative to the catecholamines. All right. Then the indirect acting, number 1, the amphetamine. Amphetamine increases both systolic and diastolic blood pressure, directly stimulates the heart, and on occasion may cause a reflex slowing of the heart. Central nervous system effects include wakefulness, alertness, decreased feeling of fatigue, elevation of mood, self-confidence, And in addition, they have euphoria, both increase and motor and speech activities. But prolonged use of this amphetamine may be followed by depression and fatigue. And the side effect is as a result of the extension of their pharmacological effects, and can include increase in blood pressure because of sympathetic overdrive, angina, arrhythmias, as well as other cardiovascular effects. While the central nervous system effects include restlessness, dizziness, tremor, irritability, insomnia, fever, and euphoria. Then they have more severe side effects of these CNS stimulants. Patient can have confusion, aggressiveness, anxiety, delirium, panic attacks, suicidal or homicidal tendencies. And chronic use can lead to tolerance and dependence. Then the therapeutic use of amphetamine could include in narcolepsy and attention deficit hyperactive disorder. All right. Then this is the summary of what I've just talked about this central nervous system stimulation effect of amphetamine, both the D isomer and L isomer. Then, okay. So in summary of the sympathomimetic class of drugs, there are a variety of, sorry, class of drug is a very important class of drug because of its use in so many important conditions. Can be used in cardiogenic shock, anaphylactic shock, hypotension, hypertension, congestive heart failure, bronchial asthma. Can be used in nasal decongestant, narcolepsy, attention deficit hyperactive disorder. While the adrenergic receptor antagonist, so the adrenergic receptor antagonists, also there are drugs that bind to alpha or beta adrenergic receptors and prevent or block the responses produced by the catecholamines or the sympathomimetics. So they're like the opposite antagonist of the sympathomimetics. Almost all of these drugs are competitive antagonists with the exception of phenoxybenzamine. These drugs, they bind to receptor sites but cannot produce a biological response. Now, the pharmacological actions or responses to these adrenergic receptor antagonists, which could be alpha or beta adrenergic receptor, depends upon a lot of factors. One, the degrees of existing sympathetic tone in the cell or tissue at the time of the blockade. That is the amount of norepinephrine interacting with the receptors, and then the type of receptor that is inhibited. Is it alpha-1 that is inhibited, or beta-2 that is inhibited, or alpha-2? Then degree and duration of blockade of these receptors, they determine the clinical effects. And the antagonists are also classified according to whether they are selective or non-selective. Then the next slide shows us the receptor antagonists. We can see the alpha adrenergic receptor antagonist and the beta. We have the non-selective, phenoxybenzamine, phentolamine, alpha-1 selective, the prazosin, the dozazocin, and then we have alpha-2 selective, the yohimbine. Then we have the non-selective beta adrenergic antagonist. The non-selective ones like the timolol, propranolol, beta-1 selective, atenolol, bisoprolol, esmolol, and then metoprolol. Then we have the generations, second generation, third generation, and the third generation of beta-1 selective. So let's go to alpha antagonists. Now, I've already talked about that, could be non-selective, as in phenoxybenzamine, phentolamine. So they block both alpha-1 and alpha-2 adrenergic receptors. The alpha-1 selective is prazosin, while the alpha-2 selective is the yohimbine. Then the next slide. Okay, still. So this slide they are very tiny, but when zoomed, we will see the action summary of this adrenergic antagonist based on the each of them, whether they are selective or non-selective, and then their prominent pharmacological actions, the therapeutic applications where they are used, and then the side effects and other comments that come onto them. So, for example, the phenoxybenzamine, the prominent pharmacological action that is decrease in peripheral resistance that are used in treatment of catecholamine excess and all that. So let's move to the next slide. So the alpha-1 antagonist. The blockage, when there is blockage of alpha-1 and adrenergic receptors, it inhibits vasoconstriction because alpha-1 is known as is more of a potent vasoconstrictor and found in the blood vessels, and therefore vasodilatation in both arteriolar and veins may occur. So the fall in blood pressure depends upon the degrees of the sympathetic tone, whether the sympathetic tone, which is higher in erect position and versus supine position. So for most alpha blockers, the decrease in the blood pressure is opposed by the baroreceptor reflexes that cause an increase in heart rate and cardiac output. Then we have the alpha-2 antagonist. Then a blockage of alpha-2 receptors will result in enhanced norepinephrine release. An activation of these alpha-2 receptors in the central cardiovascular control site will lead to decrease, as I previously said, in sympathetic outflow and a decrease in the blood pressure. All right. While the reverse, when the receptor is blocked, then we have a reverse we have sympathetic outflow. Then the most useful alpha adrenergic receptor antagonists clinically are the ones, the alpha-1 antagonists. They are used in the treatment of essential hypertension. All right. And also, in addition, can also been employed in benign prostatic hypertrophy and, also used to impede outflow of urine from the bladder through so these are the pharmacological uses of the alpha-1. Then we have the beta adrenergic antagonists. The beta adrenergic antagonists, they are regarded as one of the most important drugs to be created in the past few decades because of their efficacy in treating numerous pathological conditions like hypertension, ischemic heart disease, heart failure, certain arrhythmias, and they can be selective or non-selective. So the classification of the beta blockers, the next slide, we have the non-selective beta blockers, that some of them that have intrinsic sympathomimetic activity. Also, those of these beta blockers, there are some of them that have intrinsic sympathomimetic activity. We call them partial agonists, in as much as they are beta blockers. So we have the non-selective. You see the classification. The one with plus ISA is the ones with positive that have intrinsic sympathetic activity, while the other one does not. Then we have the beta-1 selective. We have atenolol, bisoprolol, esmolol, and nebivolol. Then with alpha blocking activity, carvedilol has some alpha blocking activity, and then labetalol. Then, in addition to being a non-selective or beta-1 selective, some beta blockers also have other actions, such as membrane stabilizing effects, local anesthetic action, or intrinsic sympathomimetic activity, as I have just said. They also could be vasodilatory by beta-2 agonism, and then alpha-1 receptor antagonism. Okay, I really do not understand this particular statement. I tried to analyze it very well, so I really need some explanation by this action of the beta-2 having some vasodilatory effects by being beta-2 agonists. So these are the sympathomimetic drugs and the adrenergic receptor antagonists, just like the summary of what I have just said and the actions of these antagonists. and their selectivity. So we have some pharmacological effects of the beta blockers. Beta blockers, they have prominent effects on the heart, including decreasing the heart rate, myocardial contractility, and cardiac output, with a noted side effect because of activation of the beta receptors. Beta blockers can also antagonize other effects like blocking bronchial smooth muscles that will lead in airway resistance. So in bronchial asthma, we avoid the beta blockers. Reduction of intraocular pressure, inhibition of sympathetic nervous system, and then stimulation of lipolysis. Then the beta adrenergic receptor antagonists that are very useful clinically. Okay, I've previously said they've been used to treat a wide variety of conditions like in ischemic heart disease, cardiac arrhythmias, idiopathic hypertrophic subaortic stenosis, congestive heart failure. Can also be found in hyperthyroidism, surgical removal. Okay, this to treat sympathetic overdrive in hyperthyroid patients. Can also be used as prophylaxis in migraine and non-Parkinson tremor. It can also be used in a wide variety of anxiety situations like stage fright and all that, and then alcohol and sedatives, patients that have hypnotic drug withdrawal. So the next slide will show the summary of the beta adrenoceptor antagonists and their effect, the prominent pharmacological actions and the therapeutic applications of this drug with their side effects in the slide. Okay. So in summary, sympathomimetic are agents, which in general, these agents mimic responses due to stimulation of the sympathetic nerves. They can act directly or indirectly on the next slide. They act directly or indirectly on the adrenal receptors, thus causing the clinical effects on various organs and systems. So careful selection of these agents, agonists and antagonists in clinical practice is of paramount importance. Thank you very much. That's the end of the presentation. Please, I need more clarification on all that. Thank you.
Wow, you just did a very beautiful job. Very beautiful. As in, you took your part to the extent that it covered a lot of MCQ questions and a lot of questions I had on my mind. You've actually addressed them. You're highly appreciated. You've been a strong support. Yeah, you've been a strong support system. So I must appreciate you for that. Please keep it up, eh? All
Thank
right.
you.
So yeah, keep it up. Yes. Okay. So the floor is open. Can we please appreciate her? She's done a great job. She has made a lot of things easy for us to understand when answering questions. Okay. So it's time for questions and then suggestions. So we'll go in an ascending order. The participants will ask their questions and then make contributions, and we'll go over to our chiefs. Thank you so much. So the floor is open to questions and suggestions. Thank you. Okay, going into the chat room, everyone is applauding you for your excellent presentation, comprehensive presentation. Everyone is appreciating your good work, your hard work. All right, so maybe I'll call people to ask questions or make contributions. Okay, Dr. Zakia, do you have any question or contribution to make? Okay, so from what you said, like before now, I was asking myself, why do we use epinephrine for cardiac arrest, and why don't we use no epinephrine? So I think from what you explained, you said epinephrine actually has effects on all the receptors, that's alpha 1, 2, beta 1, 2, and beta 3. Like it actually has effect on all the organs in the body. So I think basically it tries to revitalize the organs in that very critical state, as in my own thinking from what you just explained to us. Okay, so what else again? Yes, then there's usually a question that is, although you've addressed it, why we give dopamine is actually preferred over norepinephrine in a patient who has like a renal compromise, because it said that dopamine is actually giving causes renal vascular dilatation, so it can be given in a patient who has a renal compromise. Because before now, I was wondering why we don't give norepinephrine in such a case. Okay, so I'm just trying to recap what you said since we're actually waiting for questions and then contributions.
Okay,
Okay,
thank you.
um, yeah,
That's
I'm just trying to recap while we are waiting to see whether I actually picked up something from what you taught. Then, what else again? Okay, so but you did a great job, especially with differentiating the different classes of beta blockers, the alpha blockers, the non-selective, selective, and then the ones that have the intrinsic sympathomimetic effect. I don't know if you can highlight us a little more about that intrinsic sympathomimetic effect. I don't know if you can highlight us on that because you said
okay.
it's partial, yeah.
There was a place where I asked some questions so that, I did not really understand it properly when I was reading that in as much as there are beta blockers, but they still have within them, so they call them partial agonists. So I don't know the clinical implication of having that partial agonist. That is in clinical practice. Are there conditions that we will prefer to give beta blockers with partial agonist, agonist effect, that is has mimetic effect, and then, or are there conditions that will give beta blockers that don't have intrinsic that sympathomimetic effect? I did not understand it. I know I said it when I was presenting, but I know I saw it. That's why I wrote it down.
Okay, Dr. Contest had this up. Okay, but before he talks, the nevibolol, what class, where, does it have an intrinsic sympathomimetic effect? Nevibolol,
Never, I don't.
nevibolol.
I'm not so sure. I'm not so. But
I think that it's under selective. It's under all those
yeah, it's a
selective
selective.
beta one.
Mm.
Does it have that intrinsic sympathomimetic agonist effect? Because I know for patients who have erectile dysfunction, you can actually give that. I think because of that intrinsic sympathomimetic effect, I'm
Okay,
trying
let
to
me
think
go for
aloud. Yeah. Okay, so let's go to Dr. Conte. Dr. Conte, please, you can have the floor. I'll still go through it and then maybe probably send it to the chat room to find out why we have some ISA effects with some of them. Okay, Dr. Conte, please have the floor. Thank you.
Yes, thank you very much. And thank you very, very much, Dr. Philomena, for that very, very extensive presentation. It's a very good summary and it's been very, very helpful. Let me just throw a little light on the effect of nebivolol. So nebivolol, in addition to its beta-1 alpha and beta-1 selectivity, it has vasodilatory effect. And the vasodilatory effect is basically by increasing nitric oxide secretion from the endothelial cells. So that's the reason why it has been shown instead of all the other beta blockers that tend to cause erectile dysfunction, it actually has been shown to improve erectile function when used to treat elderly people with hypertension or heart failure. So it's because it's through release of nitric oxide from the endothelial cell. That's how it produces its vasodilatory effect. Now, coming to this issue about the intrinsic sympathomimetic activity of certain beta blockers, like Philomena rightly mentioned, the beta blockers, they block the beta receptors competitively. So they are competitive blocker. What that means is that when they are in the blood, in the system together with the catecholamines, they compete with the catecholamines. When they bind to the receptor, they cannot allow the catecholamine to bind the receptor. Okay? So ordinarily, what you expect that to cause is that because the catecholamine that are supposed to stimulate those receptors are not allowed to bind to them, then you have no effect. The effect of the catecholamines are blocked. Okay, so now what happens with the beta blockers that have intrinsic sympathomimetic activity is that even though they competitively block the catecholamines from binding to the receptor, when they bind to the receptor, they do not just bind there to block the effect of the catecholamine. They by themselves also produce some stimulatory effect on the receptor. So if it is a G protein link receptor, then they will increase the release of G protein and then cause some stimulatory effect of the, but although it will not be as strong as when the catecholamine bind to it. Okay, so that's how the intrinsic sympathomimetic effect comes about. But when it comes to this beta blocker, especially, this intrinsic sympathomimetic effect, beta 1 selectivity and all of that, they are essentially, pharmacodynamic properties, and when it comes, when you want to look at mechanism of action. But because initially, when they started discovering this sympathomimetic effect, sympathomimetic effect of certain beta blocker, they thought those beta blockers would be the perfect beta blockers to be used in the situation of acute heart failure. Because you know that in acute heart failure, even though you are having overstimulation of the sympathetic system, but that sympathetic overdrive is what is keeping the heart going, even at that acute failed state. So that is why generally the practice is someone has not been on beta blocker, when they come with acute heart failure, you don't do beta blockade, because that sympathomimetic drive that is keeping the heart going, if you block it automatically, then you worsen the patient condition. So you have to diurese the patient first and get the patient stabilized before you start doing beta blockade. So when they discovered this effect of those with intrinsic sympathomimetic activity, they thought it could solve that problem. Then you can be able to use beta blocker early, that you can block the catecholamine, but then these drugs will still intrinsically stimulate the heart to continue working. But however, when they now put them into clinical trials, then the results were completely, different. Some of the ones that they suspect, like the acebutolol, to be effective in such case, they did not show survival benefit or improvement in patients. So when you look even at the beta blockers that have improved in heart failure, you have a wide variety. You have some that are beta 1 selective, like the metoprolol, bisoprolol and nebivolol, but you have non-selective beta blockers like carvedilol, which has also shown tremendous benefit in heart failure. So those intrinsic sympathomimetic activity, beta 1 selective, they are very good to understand the mechanism and all. But when it comes to really their effect, it just depends on how the patient responds clinically. And that is actually proven by clinical randomized control trial to see when you're actually giving real life situation, does this effects really matter in terms of improving the patient condition? Okay. So that's what I would have to say concerning that. Thank you very much once again, Philomena.
Thank you, Dr. Conte, for always coming to our rescue. We appreciate you. Thank you. Okay, so Dr. Avuta, you can please have the floor. I can see your hand up. Thank you.
Okay, good evening all. Thank you very much for your wonderful presentation. Quite enlightening. Okay, I just wanted to, maybe not a question directed to the presenter, maybe something someone can throw more light on. There is this, maybe let me call it a rift between the pulmonologist and the cardiologist. When someone has a history of asthma or COPD, and also a heart failure patient. So when this person is not even in exacerbation of the COPD, and the person's heart failure requires a beta blocker, some pulmonologists will always frown most times remove it, even though you choose the very beta 1 specific ones, like the bisoprolol, nebivolol, and all, the metoprolol, trying to tell them that it is actually beta 1 selective and doesn't affect is asking for clarification from seniors and people around. is it still the way to go? Is it still the way to go? Can we do, or who is wrong in this situation? Are beta 1 blockers purely beta 1? Do they extend their effects to some receptors on the bronchioles to affect the asthma COPD, or they are really beta 1? So I just want some clarification on that.
Yeah, if I may
Thank
comment
you
on
so much.
the issue again. So like I was explaining, even among the beta selectivity, it's not absolute, and there are some literature that even try to assign percentages to the beta 1 selectivity of the beta blockers. Okay, so it's not absolute. So although if you compare the non-selective beta blockers to the selective beta 1 selective, then you have less pulmonary effect when you use a beta 1 selective medication in a patient, in a known asthma or COPD patient, compared to if you just use a non-selective beta blocker. But however, they still would have some effect. They still would, even a beta 1 selective will produce some effect, in the pulmonary system. So it all boils down to weighing your risk and benefit. How much benefit will the patient derive? Do they have a heart failure that you are finding it difficult to control and you really need a beta blocker? What's the benefits of that as opposed to the small, beta 2 agonist effect or beta 2 blocking effect that you get affecting the pulmonary issue? So it's just weighing the risk and the benefit. But however, you should know that the selectivity is not absolute. But again, you should not forget that those that are selective, they will stimulate other receptors less compared to the non-selective ones. Okay, thank you.
Thank you, Dr. Conte. We really appreciate it. Okay, Dr. Olaleko, you can please have the floor. Thank you.
Okay, thank you. Good evening, everyone. Thank you for the presentation. Okay, please, I just need a bit of clarification. I think the presenter was trying to raise there was something that was a bit not clear. That was under the beta adrenoceptor antagonist, when you talk about the vasodilatory effect by beta 2 agonism. Okay, just wanted to ask Dr. Conte that does this have to do with the intrinsic sympathomimetic activity? That's actually, I just needed a clarification on that, because there are some beta blockers that, like was rightly stated earlier, that there are some non-selective and then beta 1 selective that has intrinsic sympathomimetic activity. This intrinsic sympathomimetic activity, is it the one that causes the vasodilatory effect? Just wanted to
Yeah, the vasodilatory effects are different. So specifically, like I mentioned, for nebivolol, is nitric oxide, synthesis, stimulating synthesis and release of nitric oxide from the endothelial cells. Now you have some beta blockers that have alpha 2 stimulating effect. Those alpha 2 receptors, they are mainly what are called presynaptic receptors. So ordinarily, when they are activated, they prevent the release of catecholamine at the synaptic junction. Okay, so when they are stimulated, they hasten the reuptake and then prevent further release of catecholamines. All right, so those beta blockers that can stimulate those presynaptic alpha 2 receptors, you will see that they will produce some amount of vasodilatory effect, because at the synaptic junction, they will prevent release of catecholamine and also cause quick reuptake of your catecholamines.
Thank you.
Okay, so thank you so much. So Dr. Olaleko is asking in the chat room that nebivolol is beta 1 selective antagonist, a third generation. Okay, thank you so much. Okay, so in the absence of questions and contributions from the participants, I'll move over to our chiefs. I don't know, Chief Orimolade, Chief Okopi. Do you have questions or contributions as regards our presentation? All right, so in the absence of the okay,
sorry.
Chief.
Yes,
okay, Chief, you have a phone.
Yes, thank you. Good evening, everyone. Thanks, Reverend Sister, for your wonderful presentation. Thanks, Dr. Conte, for the contributions too. The topic has been well discussed, but it will be good for MCQ purposes, and even OSCE. Sympathomimetics can still come out. I remember we practiced this during my time when we were revising. They were part of the MC questions that we were coding. But sympathomimetics, we should please know. So you should go through her slides well. She mentioned so many things, but what helped me during my own time is to listen to YouTube presentations on sympathomimetics to help it stick. Because when you are asked in OSCE, within a period of 10 minutes, you have to say a lot and you must mention so many things. So now that we have gone through it, I think we should just maybe check it YouTube or online, how we can easily classify for OSCE purposes. Then a slide will be very appropriate for MCQs, really. Then to mention that, yes, the question about COPD or asthma and hypertension. Well, it's logical beta blocker, I mean. It's logical from what Dr. Conte said and the likes for theory, but I want us to also check online. I know that we presented it before in my unit in UCH. If I'm able to get the slide, I will send it to us. There are studies that have been done in which beta blocker is most appropriate in heart failure and COPD. So I don't know, we have to check it, but conclusion of, I don't know if the study is as recent as what Dr. Conte is saying. However, I know Cardiology is top on the list. Cardiology is top on the list. If I'm able to get that, I would send it to the group, but we should check it. Because I know that there was a debate on it, and there was an MCQ we were answering that mentioned something like that. But it could be questions that they can throw at us. So we should please really check it up. Beta blockers, sympathomimetics are very, very high yield questions for drugs in the exam. Bioavailability, their susceptibility, the one that is most potent, all those first generation, second generation, third generation, and the receptors that they block. We should please revise. Thank you so much for the presentation.
Thank you so much, Chief Orimalade, for that great input. We really appreciate it. Okay, I don't know if we have any other contributions or questions. Please, who is Zoom user? Please, can you come in with your name? Zoom user, please come in with your name, please. Thank you. Okay, so in the absence of further questions and contributions, we'll move. Okay.
Dr. Alison, thank you so much for that exam experience you brought into this presentation. Thank you so much, Dr. Ikenesi, for a brilliant presentation. When you were presenting, I was just smiling and looking at the various MCQ questions. I don't know if Dr. Siri Uzoke can make one or two comments from also some exam experience with respect to this before I make a final contribution. Dr. Cyril, are you there?
Yes, Chief, good evening.
Good evening, sir.
Yeah, that was really an extensive presentation, really. It really helped us to go through our pharmacologies. Just as the previous speakers have spoken, I think we still need to arrange them into the various groups, those that are hydrophilics, those that have intrinsic sympathomimetics, selective blockers, non-selective blockers, and all that. If we make it like it will be more handy for us going forward. Thank you.
Okay, yeah, thank you so much. So from my experience with the examiner, it appears that we've done well with respect to drugs and pharmacology, but we still have more to cover. At least we've done cardiac glycoside and diuretics. If you've noticed in the exam, right from previously, even before mine, and even those later, there's hardly any MCQ that you don't find blockers. So if there's any group of drugs you should know at your fingertips, it should be beta blockers. And also if there's a possibility of getting acronyms, it will be better. I thought Alex Itubi was inside. When I was going for exam, he did a beautiful tabulation with beautiful acronyms for the beta blockers for me. So maybe when it comes in, we should get him to either post it on the page because it will definitely come out. With respect to the question of beta blockers and COPDs, yes, there's no absolute selectivity. But I think studies have shown, I was wild for the papers, but there are studies that have shown some beta blockers that could be used in the presence of heart failure and concomitant COPD. So maybe if Alison could help us with that representation to help. But for absolute selectivity is not there. But at weighing, balancing the risk and the benefits, you could have some that the cross selectivity will not be as adverse compared to the others. So it's based on benefits outweighing the risk. But by and large, I really was so pleased by chemistry filming. Well done so much. You did extensive job on this topic that's quite confusing sometimes. Perhaps you will have some acronyms at the end of the slides to be helpful before you post them. All right, Lawrence, back to you. Thank you.
Okay, thank you so much, Dan, for your brilliant input. We really appreciate. So in the chat room, Dr. Chief Allison is saying we should try to cram things around beta blockers that it's very high yield. Okay, thank you so much, Ma, for your input. Okay, so in the absence of further questions and contributions, we'll move over to the second part of outing today, which